Us today for the Systems for Action Research in Progress webinar series. My name is Carrington Lott. I'm the Deputy Director at Systems for Action, which is a national research program office of the Robert Wood Johnson Foundation. We're housed at the Colorado School of Public Health in Denver, Colorado, and we support research projects all across the country that aim at innovative ideas of aligning systems to improve health equity and health outcomes. So when we're talking about systems, the three systems that we're referring to are the public health, social service, and public and medical sectors. So today you're going to be hearing from one of our grantees at Georgia State University. Dr. Fei Lee is leading this project, and they are presenting probably some final results here. They've been with us for a few years, and their project just wrapped up. So some of you may have tuned in for one of their previous Research in Progress webinars, and today you'll hear how things have wrapped up with their project. So their project is titled, Can Transportation Assistance Help Slow Down the Progression of Chronic Diseases? And Faye, can I get you to go to the next slide, please? Thank you so much. And so before handing it over to them to present on their research, I will go over a couple of housekeeping things. This is our agenda. We're here at the welcome right now, which as soon as I have finished going over some housekeeping things, I'll hand over the presentation to Dr. Fei Lee. And then when she is done with her presentation, we'll have some commentary from Kathy Taylor, who is joining us today from the Grady Health System. And then we will have about 10 to 15 minutes at the end of today's session for questions and answers. So if at any point during the presentation a question comes up, feel free to locate your Q&A box at the bottom of your Zoom screen, enter in your question, and we'll make sure to reserve some time at the end of today's session to ask those questions to the research team and perhaps to Kathy Taylor as well. Last housekeeping item is that today's session will be recorded. We will send out the recording as well as the slides from the presentation by the end of this week. Okay, next slide. I think that is it for me. I'm going to go ahead and hand it over to Dr. Lee. Thank you so much for joining us today to present.
All right, thank you very much, Carrington. Hello, everyone. Thank you for joining us to hear the presentation, the recent progress of our System for Action project. So like Carrington mentioned, we have been doing this for a few years and the project has ended. Now we're just waiting to obtain data for our final analysis. So we will not have all the findings, all the results today, but we are very close. So to summarize, we conducted a mixed method study examining the linkage between transportation and healthcare access, food access, and health outcomes. We're focusing on low-income chronically ill individuals in Atlanta, Georgia, mostly individuals with uncontrolled diabetes and hypertension. The study was initially designed as a randomized controlled trial where we wanted to test the impacts of several different mobility assistances. We want to follow the patients for 12 months, and we work together with a dietary program called Food as Medicine, which also could last up to 12 months for eligible individuals. But because our project launch coincided with the start of the COVID pandemic, we did encounter a number of challenges in recruitment and retention. We ended up with a smaller sample size, and most patients were not able to stay in the program for 12 months. So we combined the quantitative part of the study with in-depth interviews so that we can better understand the mobility challenges that people faced during the pandemic and how that affected their food access and healthcare utilization. So the problem that we were trying to deal with is mostly the spatial health inequity. Atlanta, Georgia. This is just a demonstration of how the differences in life expectancy can be up to a gap of over 10 years in very close by neighborhoods based on socioeconomic conditions of those neighborhoods. And we consider, although there are many other space-related social determinants of health, mobility and transportation can also be a big one. It can not only affect access to medical care and food and other services, but also very important for getting social support, participating in activities that boost mental and physical health, independent living for seniors and people with disability. So we want to look into how not only how transportation and inequities can shape health disparities, but also how can we help mitigate that. So we do have long-term studies in the literature showing that transportation barriers can be one of the factors that deter people from getting to their doctor appointments. It can affect healthcare utilization. It can definitely affect access to healthy food and therefore dietary choices. And we know public transit services can be inadequate in neighborhoods in need, especially people who do not or cannot drive. And people who are chronically ill and people, seniors are already facing limited mobility and accessibility, especially in the past few years, this COVID-19 pandemic also worsened many of these challenges. And our questions are, how do these individuals who are low income and with chronic diseases navigate the transportation system to obtain medical care and essential services? So in the spirit of Systems for Action, we were looking at the connections between these different systems, the healthcare system, food, and transportation. And we want to also test different solutions, different forms of mobility support, and see how they can help these people better utilize the existing resources and manage their chronic medical conditions. We want to also learn, from the in-depth interview, like I mentioned before, their own coping strategy and additional challenges that were brought by the COVID pandemic. So we were partnered with Subsidized Medicine, which is itself a cross-sector partnership that aims to address both food insecurity and chronic disease management. It was led by Grady Health System, where Grady is from today, which is the largest safety net hospital system in Georgia. And Grady serves mostly the communities in need, the distressed communities and underserved communities in the city of Georgia. And a lot of those, like we will see in a bit, facing both food and transportation insecurity. So working together with other agencies like the Atlanta Community Food Bank and Open Hand, Georgia, Subsidized Medicine targets initially patients with uncontrolled diabetes in Grady system, and later they expanded to patients with stage 2 hypertension. The procedures, once the patients were referred to the program, if they decide to participate, it involves biweekly or twice a month food pickups. These are free food that are prescribed to them. So like food as medicine, instead of prescribing drugs, they were prescribed healthy food, healthy plant-based food to help them change the dietary choices. And there are also cooking and nutrition classes that help them learn how to prepare these food and how to cook for according to their health conditions and to better manage blood sugar and blood pressure. They can re-enroll. So the first enrollment will last 3 months, and they can re-enroll for up to 4 episodes in total. That's up to 12 months or 1 year participation. The criteria would be they have to participate in the previous 3-month episode, minimum number of food pickups and cooking and nutrition classes. They participate in order to continue renewing their participation in Subsidized Medicine. So the program started in August 2020, and so far, Subsidized Medicine have served over 1,000 patients, including those with diabetes and hypertension. This is a map showing the target community for Grady Memorial Hospital, which is the main hospital that we were working with, and also where the food pharmacy was located at in city of Atlanta, as marked here. If some of you are familiar with the geography of Atlanta, you might know it's a very segregated city, both racially and economically. And the south and the west side of the city is lower income and mostly African American or Black population, and north side of the city is more wealthy or white and middle income. So as you can see from this map, the target communities where most of patients at Grady Memorial Hospital are from are those communities in need, and also with the red dots representing the communities with the highest social vulnerability indexes. So that also largely overlap, like shown in this map. This is the percentage of households with no vehicles, no access to private vehicles, which would be a little surprising in a city like Atlanta, which is very much automobile dependent, but still in some of these, the darkest color census tracts, you can see it can be up to 20–30% of the household without vehicles. We also have the public transit networks mapped on this map, and you can see these neighborhoods are mostly served by the local transit agencies, but because of the limited support for public transit overall in Georgia, even with these extensive bus lines, sometimes people face difficulties such as long wait times, buses not on time, and just like too far a walk to the bus stop or the train station, or the first mile, last mile problems, making their utilization of the transit limited. This is a similar map showing the home locations of our participants in our study. And based on the completion of surveys, we actually have more signed up. We have over 300 people participating, but some did not complete the survey. So we have 263 survey respondents, and the distribution of their home location very clearly matched that of the target community of Grady Memorial Hospital and those neighborhoods experiencing transportation insecurity. So here's a summary of our study design. We partner with Food as Medicine, and we basically recruited participants through Food as Medicine, and we give them a flyer describing the project, and they have an option of signing up while they enter Food as Medicine. So we target specifically participants with transportation challenges, but that would be the majority of Food as Medicine participants to some extent. Then once they enrolled in the study, we randomized them into 4 different branches, including a control group and 3 groups receiving different types of mobility assistance. One group is receiving 10 free rides on the public transit system per month. The second group is receiving an equivalent amount of cash, $25 per month. And the third group receives mobility counseling instead of any monetary assistance, with the idea that there are already many existing programs and existing resources that many of these participants might be eligible for example, programs that offer free transportation for seniors or discounted transportation for seniors. So the idea is through counseling, we can connect them with these programs and help them utilize existing resources. So each of these experimental groups will provide the assistance for 12 months, but in reality, that will be as long as they stay in Food as Medicine. We designed 5 waves of surveys at the baseline when they entered the study, and then 3 months, 6 months, 9 months, and 12 months. So every 3 months. And later we also added in-depth interviews when we realized that retention or the expectation of people staying in the program for 12 months has become unrealistic. So here's a conceptual model of our expected outcome variables. We were hoping that working in conjunction with Food as Medicine, which provide these food support, we are providing transportation support, which could help people get to their food pickups, their appointments at the food pharmacy, but also should be able to assist them with other purposes of transportation. So hopefully with that, we expecting that will help their healthcare utilization, meaning more participation or more utilization of primary and routine care and less dependence on emergency care. We expect to see more participation in activities enhancing physical and mental well-being. And we expect to see changes in their dietary behavior. So all of these should also contribute to improving their physical and mental health outcomes. So we included a number of variables here to watch, but for people with diabetes, the main indicator would be A1C, and for those with hypertension, it would be blood pressure. This is a summary of participants' profile, and some of these questions are from the questionnaire they complete when they enter for this medicine, and some of these are from our survey with the transportation study. So not all participants have responses with both, with all of these questions. Like this question is specific for our study. Well, first of all these participants in general, for this medicine, majority Black or African American, more female than males, and average age approaching 60 years. And if you look at some of these, housing, food stamps, and health indicators, our participants, so people who sign up for our study, tend to be, a little more. A little more housing insecure and more utilizing food stamps. And also they tend to be sicker than the general population participating in food as medicine. And these are questions all specific to our study because we asked specifically what mobility options you have access to, and including technological access, because we consider, especially in the years of COVID-19 pandemic, that virtual access can very much be a substitute of physical travel. But as we can see here, many of these individuals do not have great access to digital technologies. Like only 60% have internet access on the home computer. This is mostly because of the lack of a home computer. And only a little over 80% have internet access on the mobile device. Less than half have access to a car, a private vehicle, and also only 55% are able to drive. This is both because some don't have a driver's license and some are too sick to drive and can only drive maybe some of the time based on their health condition. So these are some of the metrics we also want to look at regarding healthcare utilization. So we aggregate the number of visits during the 12 months after their enrollment in food as medicine. And remember, I mentioned before, we realized that many of these participants actually don't sign up for all 4 episodes. They don't get renewal at some point, maybe after the first or after the second episode, they stop participating. So this is not covering all the participants either in our study or in food as medicine, because these numbers are from a earlier report from Grady. At the time, we were looking at those who have been who enrolled at least 12 months ago, so that we can compare the number of participants, the number of visits in the 12-month period. And we do see a little bit of difference between, if you look at the food as medicine visits, these cover the food pickups, the nutrition, and cooking classes participation. And there's the average of 15.6 number of visits from our participants compared to a little over 11 in the general food as medicine participation. So this may or may not be indication that some of our support are encouraging people to come back more, but it can also be self-selection, meaning more motivated participants from food as medicine are more likely to sign up for our study. When we look at our participants, depending on which group they're in, and unfortunately, as you can see, we plan to do 5 waves of surveys, but there's serious significant attrition between the different waves. Like we start with a similar number of patients in each of the groups, but in the end, very few people finished the fifth wave of the survey. You can see that the cash group seems to be the most motivated to stay in the study. But overall, the sample size just seemed too small in the later waves of the survey to be able to detect the kind of effects we want to. So we do plan to expand the quantitative analysis to the entire population of food as medicine so that we can use that as a comparison as well, instead of just our own control group, which ended up with a smaller number of respondents in the later waves in the survey. This is a demonstration of what different kinds of activities they participate in. We asked this question as in, how often do you go out for this or that different kind of activities in the past month? So we can see that grocery shopping and medical, because this bar on the left side, meaning they answer never. I never did that in the last month. So very few of them have regular work or school. Like the response for participating in social recreational activities or obtaining services, meaning like going to a bank, going to a public office, not that frequent. Whereas going grocery shopping and going out, for medical related services, these seem to be the two most essential type of activities for these individuals. So we consider these to be also the essential needs for travel in this population. And from our in-depth interviews, we do observe that people do mention the different kinds of transportation barriers. We also asked about their access to virtual technologies, including telemedicine, which became more popular during the pandemic. And we also sense a overall low level of acceptance or even familiarity with those technologies. So multiple reasons that people still need to go out physically, but also find that challenging. So like for this participant from her interview, she reported at different point that she didn't have transportation. So part of that was because of the health condition she was in, but also because her car broke down and she was not able to go either to the store or to doctor appointments, and having to ask someone else to drive her. Usually that involves some negotiation, like how much to pay that person, and sometimes she felt like she was not offered a good price for that service, and you have to pay for everything. So combined with financial reasons and health reasons, that ended up with her being in the transportation insecure situation. And she also said, because of that, I ran out of medicine, and I have nobody to take me to go get it, and I haven't had no medicine in over 3 weeks. This is another example mentioning that this participant limited going out because of the expense of gas. So this is someone who has a car and was able to drive, but even then, the where to go and where not to go might have been influenced by the fact that the cost of driving became too high for their budget. And then for this participant, they don't have a car and they use the public transit system locally called MARTA. They also utilize the senior transportation program, which we found that many of these participants use. So as part of our mobility counseling arm, that we discovered these different kind of services and programs available to these low-income chronically ill patients, and we try to tell them that or help them sign up if they need help. But what we found is a lot of these individuals are already very much aware and can be very resourceful. They can seek help from friends or neighbors about these programs and resources, but still somehow it doesn't fulfill their transportation need. So she was mentioning that the common courtesy is this senior transportation program offered by Fulton County, and it was one of the more satisfactory services she had got. Whereas her insurance transportation, which is the non-emergency medical transportation offered by health insurance, that has been problematic. They've been making me miss a couple of appointments because it was not on time, or they don't show up. And when she was doing the calculus of using MARTA, so the transit pass, like the one we are giving them, for example, 10 rides for the MARTA group, if they purchase those 10 rides, each ride costs $2.50. But if you purchase as a bunch, you can get lower rates. Say if you get 40 trips at one time, or if you get a monthly path, you actually pay less than $2.50 per ride. But because spending that much money, like paying that large sum of money for these individuals can be challenging. So they don't get to enjoy that discount. They often have to put just a little bit or just put cash on the card, and they actually pay the higher rate because of that. So like the calculations she's doing here, actually she's getting reduced fare because of her senior status, but still thinking about like paying for MARTA Plus for a year that is $120 a year, still was a challenge for her financially. So here we did a bit of a modeling from the survey results only, because we haven't got all the health indicators to look at. We do want to do similar analysis for the health outcomes and also include the rest of food as medicine participants as a comparison group. But so far, within our sample of 263 participants, and note that for later waves of surveys, the sample size get even smaller, we haven't been able to detect any significant noticeable effects on the three things we looked at from the survey. One question is about the monthly transportation budget. Like how much do you or your family spend on transportation related expenses? And we asked them about the frequency of medical related trips. All this was like in the last month. So we have a baseline level, how often you go out for medical related trips in the last month. And then in the 3, 6, 9, 12-month surveys, we asked similar questions. How often did you go out for those trips in the last month? And we expected to see an increase here, but as you can see, not only there are no significant coefficients here, but also everything seems negative. Financial anxiety, we do ask them to grade the level of anxiety they feel about their financial situation, which we were hoping that helping their transportation budget could also help that, but none of the effects was significant. The effects on monthly transportation budget might seem a little bit more interesting because we see some different signs in these effects. Like, for example, sure, giving them MARTA cards should help reduce their spending on transportation, because now they might not need to spend on MARTA rides anymore, or they need to spend a smaller amount, but again, it is not significant. So as of now, we we have coded all the in-depth interviews, and we are doing the analysis of the codes. We are waiting to do the final analysis of health outcomes, but both based on the group assignment and also comparison between our experimental groups with the remaining food as medicine participants who did not participate in our study. We also have a lot of observations, and maybe we can synthesize that into another short piece on the challenges of conducting experiments in vulnerable populations during a pandemic, because many of these participants were facing higher risks if they contract COVID, so many individuals are scared. it could be a factor for them discontinuing participation in fitness medicine and therefore our study at some point. So that is what we have for now, and thank you again for joining us today. So I suppose we can hear a little bit more from Kathy on the background of this program at Grady and the partnership.
Right. So currently, we have over 2,100 patients who have been enrolled in the program, and transportation continues to be an issue. We have partnered with United Healthcare to provide us with some common courtesy rides and work through an algorithm with our patients to ensure that we minimize the transportation barrier as much as possible. But as you saw in one of the slides that Faye just showed, that even the areas where there were decreased vehicles for our patients, that area also has a decreased life expectancy. So it is, you see the commonality of all of these different social determinants of health and how that's affecting our patients. So we're grateful for this partnership with Faye and her team to address this and to bring it to our attention of how this is even making a difference for our patients. In the last year, in 2022, we saw that our patients who completed the program, who graduated from our program, had an average of 2.4% decrease in their A1Cs for those with uncontrolled diabetes. We looked at the data for this past year, 2023 graduates, and we're seeing still on average a 2.1% decrease in their A1C. So we know this this program is really important for our patients, and to get them here, to get the food, the resources, the nutrition education component that goes with it, and as a follow-up to their medical appointments. It's all critical components for their care. And so we are continuing to work through those barriers and to get our patients here.
Thank you so much, Faye, for presenting on your presentation, and for Kathy for joining us and speaking on behalf of the partner health system in Grady. We are at the Q&A portion of today. I see that we have one question that's been entered in the Q&A, but I invite you, if you have any questions, big or small, just enter them into the Q&A box and we'll ask the research team. I'm going to move to our first question here, which is, maybe I missed this, but I am wondering about Medicaid funding for transportation for medical services. Was there an effort to link people to NEMT through managed care plans?
Yes, we actually worked through an algorithm to see what the patient has, if they have any kind of insurance support, if they qualify for any kind of senior programs, and try to connect them with that. And we have a patient navigator who does that specifically as a part of the program. So we do try to connect them with any opportunity they have for transportation.
Great. Thank you, Kathy. Next question from Andrew. Thank you for the nice presentation. I'm curious how COVID-19 impacted the availability, reliability, and perceptions of public transportation among Group 1. Do you have any data or thoughts on this?
So that's a great question. And we actually have already published a paper on the use of public transportation since COVID among this group. I mean, not specifically Group 1, because as you can see, that's a much smaller number, but we look at overall 260 utilization of public transit. So we are in a place where we can compare their pre-pandemic utilization of transit and their current or end of the pandemic utilization, because we asked those retrospective questions, as in what was your travel habit or travel mode before the pandemic. So what we observe here is pretty consistent with other studies looking at the travel behavior changes because of the COVID-19 pandemic, is that lower income individuals, and in our case, both lower income and also facing a number of other factors causing financial and transportation insecurities, they tend to have the least behavior changes because of COVID, regarding, continue riding public transit and continue going out, trip making. We believe this is because of the lack of alternatives. So we do see if they have a car, it's less likely that they continue to use public transit. But because many of our participants do not have cars or cannot drive, so to a large extent, they continue to use public transit. We do ask questions about perception in our interviews. In our in-depth interviews with a total of 37 participants, we don't have a significant number from group 1 to tell how much our incentive or our support of 10 rides a month have made a difference or not. But we sense that for certain individuals who are more careful, they do say, I stopped going out or I stopped going on the train or bus. But mostly it's more like, yes, it was scary initially, but I learned to deal with it because what else you can do? So people do talk about wearing masks, wearing 2 masks, having hand sanitizers and wipe everything down, but mostly they continue to use transit as the important means of transportation.
Thank you, Faye. I'm going to move on to our next question here from Rhonda, which may lead to you two connecting offline here, but their question is, are you willing to partner with other research teams doing similar work? Which I guess might be a larger question about expanding more on next steps with your research and what you're doing next.
I am assuming this is a question about food as medicine, or is it a question about the research team?
So Miranda, I think you had the ability to type into your question to maybe expand on that, and we can move on to our next question until we hear more from Miranda. Does that sound okay? Okay, I think this is a follow-up to the question that was asked earlier, Kathy, that you answered. But how many of the patients you serve actually qualify for insurer-covered NEMT?
I honestly don't know what that percentage looks like. Our population is mainly Medicare, Medicaid, so it's not highly insured. So probably pretty low percent, probably 10 to 20%, if that.
Okay, thank you. And I think that's fair that you don't have the exact answer. We did not ask you to prepare that for this presentation, so thank you for doing your best. I have not a question here, just a comment on thank you for sharing this important work. This person is very interested in the connection between chronic disease management and access to essential destinations, and they're looking forward to sharing this information with their colleagues. So just thank you. Rhonda has clarified a little bit more. So yes, food is medicine and other intersectional barriers for this demographic. And that was related to the question, Faye, about partnering with other researchers.
Right. As far as I know, Food as Medicine is still partnering with many research groups, but Kathy, you can comment more on this.
Yes, we are working with several groups with Emory to work through the data to connect more of the information that we're receiving from our work, but it's been a little bit of a slow go, only because we have such a small team, and it's just kind of a bandwidth situation right now. So, but yes, we do have a research and evaluation group that is trying to work through more of this with our Emory partners.
Great, thank you both. Next question here, or I guess before moving on to that, we do have another Systems for Action project that is looking at food as medicine. It's in a different state, and I'm looking to see when their next research and progress webinar is. If I can't find it quickly, we can include it in our follow-up email, which will have to be the case. But you might be interested in tuning in for that research and progress webinar to hear what they have to say about what they're learning about food as medicine as well. Moving on to the next question, can you describe a little bit more about the mobile counseling and what it consists of? Does it consist of caseworkers, or is there direct assistance with scheduling participants and their transportation?
Yes, so our mobility counseling was designed based on the model of something called solution-focused therapy. We formed this manual based off what was used for financial planning, but usually in a transportation planning kind of way. It was mostly carried out by a PhD student who is also a licensed social worker. So in this process, we do not go ahead to make transportation arrangements for people, but it's more like we ask people about their experience of going around and trying to schedule or trying to arrange transportation and identify what are the challenges. So basically, we encourage themselves in talking about the experience to identify where are the challenges and what are possible ways they can bridge that gap in wanting to go somewhere and not being able to. And then based on our knowledge of the available resources in the region, which might be eligible for this patient, and she might suggest, and she might, depending on the conversation, they might say they've already tried that or they are aware of that. What was the reason they are not using it? And if they need information, then the counselor will provide that maybe in a follow-up session. Or sometimes they might give advice on what they can look into, but she does not go ahead to fill in or to make those arrangements for them.
Thank you, Faye. Moving on to what appears to be our last question for now. So I invite anyone else, if you have questions, now's the time. This question is asking about when you're asking clients if they have internet access through a home computer, what does that help measure?
Yes, so that is a measure of access to virtual technology, which can be oftentimes a substitute for other forms of transportation. So this has become more prominent during the pandemic, but even before, we consider, there are many activities that require travel can be substituted by doing things online. So we ask that in a way we want to assess how prevalent these technologies are among this population. And also in our survey and interviews, we also ask people the frequency of them doing things online, doing these different things, including telehealth. So our finding regarding that is people do that very rarely among this group. And in the interviews, we ask more about why they don't do that. Sometimes because they don't like it, but more often because they don't have the kind of skills and the confidence to do those.
Thank you for explaining that. Another question has come in from Rhonda. Were there any public safety considerations with data for transportation?
Would that be about like traffic safety or crime or what?
I'm not sure. Rhonda, do you want to expand on what exactly you mean? Both.
Yes, so that would be a question that we can partly answer through the data from our interviews. We do have people mentioning, and depending on where they live, this can be also one aspect of the transportation barriers, especially for those utilizing public transit. There are people who mention it doesn't feel safe to go to the stop, even if it's close by, there's no crosswalk, and they might be walking on a walker, they don't want to cross the street. And there might be, you know, gangsters hanging out in the neighborhood. They don't feel safe walking outside. So these can be all considerations deterring people from using certain transportation modes.
Terrific, thank you. Okay, I don't see any other questions. I'll pause here for a minute. Oh, Rhonda has popped in with another one. Thank you, Rhonda, for all your questions. What effective automated systems are in place?
Would that be a system for managing family patients or?
Rhonda, I'm going to ask you to clarify again, and I appreciate how quickly you're able to clarify in some of these questions. Outcomes.
Automated system for our program in terms of the outcomes here at Grady?
So if that's the case, I suppose that's probably something we are now trying to work on, right? The data side of things.
Right. We do have, and worked on for a long time because we collect a lot of data on our patients on every episode that they are enrolled, and we enroll them. If they last through the whole program, we enroll them at least 4 times. So we have lots of data to look at, and we're working with our BI team to consolidate that and look at that a little closer.
Great, thank you. Another question came in about explaining the negative association between transportation subsidy and medical visit.
Yes, so this would be something that is not expected outcome because we were hoping to see more medical visits for people we give support either through transit rides or money or mobility counseling. So that result, I would say, because it's not statistically significant, we tend to think it's just because of the small sample size and the noise in the data. But otherwise, if we do found a significantly negative association, it would be, I guess, an indication that our interventions are not working as intended, or over a longer term, if it does work as intended in other outcomes, as in, helping people get into other kind of social activities or physical activities that improve their health, and we do see improved health outcomes. It can be that they don't need as many doctor appointments as they used to, but that's not, we don't have enough other data to decide either way. Currently, that just seems like insignificant results.
Thank you, Faye. Okay, we've reached the end of our questions again. I think it is probably safe to assume that we have reached the end of our Q&A section, which we just have a couple of announcements here at the end. So Faye, I'm going to ask you to move to the next slide, please. We do offer a certificate of completion for attending today's webinar. So if you would like one, you can indicate in a post-webinar survey that you would like one, and we'll get one to you in a timely manner. Next slide, please. So as I mentioned at the top of the hour, this is an ongoing research and progress webinar series. Our next presentation will be on March 27th by a team at the University of Minnesota presenting on their project on systems alignment to optimize health services for youth experiencing homelessness. So we will send out in the follow-up email a link to register if you're interested in attending for that presentation. Next slide, please. I think that brings us to the end. Faye and Kathy, thank you so much for joining today to talk about this important research. And Faye, I know your project is still ongoing a little bit as you're finishing up some final analysis. So if anyone is interested in hearing some final results, definitely sign up for our newsletter, and we'll definitely be sharing their findings there. Or you can access this team's web page on our website, which I will put in the chat here. And all of their products and findings will be listed there as well. Thank you again for joining today, and I hope everyone has a wonderful rest of their day.
Thank you very much.